Hello, my name is Marcy Weinstein, and I am doing my presentation for my Disabilities course on stigma with borderline personality disorder. There is a large body of research confirming stigma towards the diagnosis of borderline personality disorder. This research is primarily focused on the attitudes of health professionals towards BPD. Researchers found health staff have strong reactions to this diagnosis, with more negative attitudes compared to various other psychiatric diagnoses and less empathy. It is widely recognized that stigma and discrimination related to mental disorders can have adverse effects on self-esteem and help-seeking behavior, which can in turn have long-ranging effects on an individual's quality of life and health outcomes. According to Lincoln Pelhan, the 5 major components of stigma are labeling, stereotyping, separation, status loss, and discrimination. There are multiple reasons why this disorder may attract stigma. Firstly, BPD is historically known as having a lack of effective treatment for its symptoms. A low optimism for change has contributed to negativity regarding this diagnosis. Secondly, being an Axis 2 diagnosis rather than an Axis 1 might cause some to assume that BPD is not as important or alarming, and therefore those suffering from this disorder can be seen as less deserving of support. Avraham, Brodsky, and Stanley suggest that staff may believe these clients have more control over their symptoms than clients with other diagnoses. Self-harm behaviors are associated with negative attitudes from health staff and are viewed as being largely manipulative in intent. One symptom of this disorder is recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. Borderline personality disorder is estimated to affect 2% of the population. 75% of those diagnosed are women, but research does suggest that men may be just as affected, but often are misdiagnosed with PTSD or depression instead. According to the DSM-5, BPD is a cluster B personality disorder described by a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of these following symptoms. 1. Frantic efforts to avoid real or imagined abandonment. 2. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. 3. Identity disturbance, markedly and persistently unstable self-image or sense of self. 4. Impulsivity in at least 2 areas that are potentially self-damaging, such as spending, sex, substance abuse, reckless driving, or binge eating. 5. Recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. 6. Affective instability due to a marked reactivity of mood, intense episodic dysphoria, irritability, or anxiety usually lasting a few hours and only rarely more than a few days. 7. Chronic feelings of emptiness. 8. Inappropriate, intense anger or difficulty controlling anger. 9. Transient, stress-related paranoid ideation or severe dissociative symptoms. Practitioners have a tendency to minimize symptoms and overlook strengths in individuals diagnosed with BPD. In general, people tend to distance themselves from stigmatized populations, and evidence shows that some clinicians may emotionally distance themselves from those with BPD, feeling unsure how they can be of help. This distancing may be especially problematic in treating patients with BPD. In addition to being unusually sensitive to rejection and abandonment, they may react negatively by harming themselves or withdrawing from treatment if they perceive this distancing and rejection. Clinicians' reactivity may be self-protective in response to the behaviors associated with this pathology. Stigma can influence the clinician's reactivity, exacerbating those same negative behaviors. This result is a self-fulfilling prophecy and a cycle of stigmatization to which both patient and therapist contribute. The extent to which therapist distancing is influenced by stigma is an important topic that highlights the possibility that the stigma associated with BPD can have a large contribution to the poor outcomes with this population. Cecile Deans and Elizabeth Masovic conducted a study on the attitudes of registered psychiatric nurses towards patients diagnosed with BPD. The results showed attitudes held by 65 registered nurses employed in a psychiatric inpatient unit where individuals with a diagnosis of BPD received treatment. Results showed that a proportion of the nurses experienced negative emotional reactions and attitudes towards people with BPD. A majority of nurses perceived people with BPD as manipulative. Almost one-third reported that patients with BPD made them angry, and over one-third either strongly disagreed or disagreed they know how to care for people with BPD. Another study conducted had nurses complete questionnaires relating to 3 psychiatric labels: BPD, schizophrenia, and depression. Registered mental health nurses expressed less social rejection towards patients with schizophrenia and perceived them to be less dangerous than those with BPD. Staff were less optimistic about patients with a BPD diagnosis and were more negative about their experience of working with this group compared to the other patient groups. The stigma associated with this disability has an alarming effect on the treatment and outcomes for individuals with this diagnosis. Before treating someone with this disability, clinicians and staff are going into treatment with negative assumptions and outlooks on the patient, thereby increasing this individual's suffering and ability to receive equal treatment. In order to lower this stigma associated with BPD, more education and training on the disorder and how to effectively help those suffering from it needs to be given to health professionals in all fields. Whether a person with BPD is seeing a gynecologist or a psychiatrist, either way, this stigma that comes with this diagnosis affects how they are treated in their daily lives. I will now discuss how the 4 models of disability, medical, moral, minority, and social, can be applied to this topic. According to the medical model of disability, humans can be perfected and biological or physiological inferiority is put upon disabled people. In the case of BPD, the medical model of disability believes those with this disability cannot be perfected like the rest, and attention is paid to identifying their differences and diagnosing them. Attention and research needs to be focused on how to find helpful treatment and provide support to those suffering from it. The moral model of disability believes having BPD is a sin and people with it as evil and bad. The minority model exemplifies how segregation, separateness, discrimination, and subordination of those disabled by BPD is similar to those of certain ethnic, racial, social, and gender groups which are viewed as minorities. The social model of disability sees that it is society, social discrimination, and biases that produce disability and exclude or disadvantage certain individuals. People become disabled with BPD through encounters with societal barriers that we just do not adjust to them, rather than them changing to adjust to society. If we removed attitudinal, physical, and institutional barriers, we would improve the lives of disabled people, being able to offer them the same treatment and opportunities. There would be no disability of BPD in a fully developed society. Social workers can be of help by advocating for more education on dialectical behavioral therapy to be given to healthcare providers. DBT is currently the most helpful evidence-based treatment for BPD. Not all criteria are met by those suffering with this disorder, and therefore a cycle of anticipation when dealing with BPD patients leads to a self-fulfilling prophecy. It is possible to treat those with BPD the same as those without it, in an empathetic and caring way. Being sensitive around those with BPD rather than scared is key. Accepting the reality that many people suffer from BPD and live full lives is also important. Many people with BPD have stable relationships, do not self-harm, hold stable jobs, and are important parts of their community. Remembering this can have a positive impact on how we view this disorder and treat those with the diagnosis. Particularly with a strengths-based approach is recommended. In a study conducted which interviewed those suffering from BPD on the way they have been treated by health staff, a prominent theme was the theme of connecting, which referred to a professional building a relationship with the individual through taking time, showing interest, and communicating care and respect. This was desired and was a large part of the positive interactions felt by those suffering from BPD. In this study, helpful behavior was categorized as seeing the individual rather than the diagnosis, inquiring about what is going on rather than assuming what is going on for the client, treating them with compassion rather than contempt, staying calm and centered rather than getting overwhelmed by the drama or caught up in it, seeing the individual's strengths rather than focusing on the negative behaviors, taking the individual seriously and validating them rather than dismissing their pain or point of view, and being hopeful about their future rather than believing things cannot change for the individual. Social workers should be noting that communicating hope in the ability of BPD paid clients to change works directly to contrast the stigma that BPD is a hopeless diagnosis and is supported by research that change is possible and also realistic. Thank you.